Recording in progress. We will be starting with the blood flow disorders slide deck and then move on to the cardiac slide deck in a bit. So we'll start with this. We'll probably take a break after this one is done and then move into the smaller slide deck of ischemic heart disease, acute coronary syndromes, and whatnot. Slide advancer here a little bit. All right, so learning objectives, 2 slides worth of them for you to review on your own, should be fairly complete. So that the outline for today, building off of what Dr. Shahid presented the last time we met, is kind of taking that dyslipidemia into clinical focus with really much greater focus on the development clinically of atherosclerosis, and then as it pertains to certain disease states. We'll first talk about certain arterial disorders that are related to, yes? On D2L? It should be there. I posted them, unless for some reason it was. Do you see the other one, or just the cardiac one is there? Okay. I posted it, but maybe for some reason it got hidden inadvertently. Okay, it should now be, for some reason it was hidden. I don't know why. I didn't do it, or at least I didn't intend to do that, so you should be able to see it now. Somebody can confirm that you can see it. Got it? Okay. My apologies for that. All right. Okay, so hopefully y'all get that up and running. So what we're going to talk about is first arterial disorders that are mostly non-cardiac in origin, and then secondly venous disorders, and then as you'll see with the second slide deck, we'll get back to arterial disorders focusing on really the heart per se. Okay, and actually from here on out we're just going to be talking about disorders of the heart for the rest of the course. So that is our outline today, but all of it somewhat related to atherosclerosis for the most part. Okay. So building off what Dr. Shahid mentioned last time, I know he talked about a variety of different lipids that we do have circulating in our body. So just for reference, and actually these thresholds of normal are something that I would expect you to know. So either be able to recite what those normal levels are, or be able to recognize, for example, an LDL of 150 is abnormal, it's too high. Okay. So be able to recognize those circled thresholds. But ideally, we want our total cholesterol below 200. Of all of those, compared to LDL anyway, the LDL is really what we're most concerned about of the variety of different cholesterols that we measure. So the LDL, if you recall, is what's considered our bad cholesterol, right? And when we have that excess of that, overwhelms the ability of our liver to take up a LDL, and then excess then gets taken up by certain areas of your arteries that are inflamed or damaged from a variety of reasons, and they begin to accumulate there, causing the atherosclerosis. So ideally, we want an LDL that's fairly low, less than 100, ideally. HDL, if you recall, is actually our good cholesterol. Okay? The more we have that circulating, the more it returns cholesterol to the liver so that it can be recycled and not deposited in the arteries, if you will. Okay? And then triglycerides are the last component that we measure clinically. We'll get all of these on the lab. We get lipids, probably we've all gotten a lipid panel before, perhaps. And triglycerides are included in that. But from a cardiovascular standpoint, there's a little bit less, quite a bit less data linking high triglycerides to cardiovascular disease. I'm not saying that it's absent, it's just definitely not in the same realm of importance as LDL and then HDL, for example. Okay? Still has its importance overall, but from a cardiovascular standpoint, not the main player for cardiovascular disease. Okay? So when you get lipids measured, hopefully if you have gotten them measured, you've been asked to fast beforehand. And the purpose of that fasting, usually 12 hours in the case of lipids, is that you're not measuring the chylomicrons. Okay, or I think Dr. Shahid referred to them as the ultra low density cholesterol, right? Can be referred to in different ways. So we don't want to measure those chylomicrons or the intermediate density lipoproteins. One, because they don't have a lot of predictive factor by themselves that they can skew the result if they're being measured. So we get it in a fasting state whenever we can. If for some reason we get it in a non-fasting state, really the only accurate numbers you can go off of are total cholesterol and HDL. Okay? LDL is technically not directly measured, but it's indirectly calculated based on total cholesterol, subtracting HDL that's measured, and then an estimate of VLDL, which is triglycerides over 5. So when you eat, your triglycerides go up, right? And so that'll throw off that calculation should you be in a non-fasting state. Okay? What are the risk factors for atherosclerosis? Okay? And I guess I've used the term, but we should make sure we know what atherosclerosis is. It can be kind of a variety of things, beginning from very minor to significant plaque development. So these are plaques that develop within the arteries. Okay? They typically begin as what we call fatty streaks. And I'm sorry to say that probably every single one of you probably has fatty streaks in your arteries. It's just part of growing up, aging, that's where we begin. Okay? Where you go from there just kind of depends on your diet, your lifestyle, and that sort of thing, right? Could be some minor plaque formation or could be some significant plaque formation. It just depends on all of these other risk factors that come into play. So obviously, as we mentioned, LDL being one of the most important. We have elevated LDL concentrations for long periods of time, which is can be related to genetics, but it also is highly related to diet. So that's bad. HDL being low, typically less than 60 is a risk factor. That decreases the cholesterol removal from the circulation and promotes it going into the arteries again. But other things that you may not recognize, obesity is a risk factor. It's thought to create a pro-inflammatory sort of state, which can damage blood vessels. Similar to cigarette smoking, the toxins damage blood vessels, damage the endothelial cells, promoting that pro-inflammatory sort of state. Hypertension and diabetes are really, really important. Hypertension by itself creates shear stress against the blood vessel itself, stretching it, relaxing. Over time, that causes damage to the endothelium as well. And then diabetes has the ability to do that, similar damage, but also decreases LDL removal from the circulation, typically decrease lipoprotein lipase activity, which increases triglycerides, is a definite pattern. Importantly, the presence of hypertension and diabetes is not just additive. In other words, it's not just double the risk. When they're together, the risk increases almost 5 to 20-fold, depending on if you have them for prolonged periods of time. So having both hypertension and diabetes is a significant synergistic risk, not just additive numerically, if you will. Other diseases such as hypothyroidism decreases LDL receptor production. Remember that having receptors on your liver, for example, aids in the uptake of LDL and removes it from the circulation, which is a good thing. And then a variety of other things that are lipoprotein concentrations, homocysteine can oxidize LDL, which makes it more toxic. So all of these things are considered modifiable. We can change all of these things and decrease the risk of somebody developing atherosclerosis over time, if you intervene early enough, obviously, and decrease, hopefully, coronary artery events by managing these. Non-modifiable things, gender, for example, females are typically protected to a certain extent as they age until they get to menopause, and then they lose the protected estrogens as far as their effects on LDL. So estrogens promote LDL receptors on the liver, for example, and promote removal of cholesterol from the circulation. That's why probably part of the reason, anyway, that typically, if you're talking about coronary artery events, females tend to get them a lot less than males until they get to postmenopausal age, and then everything kind of evens out after that. Okay. And then lastly, genetics, which we'll talk about a little bit. We certainly won't go into a lot of detail there. Okay. So this is the only kind of genetic related disorder we'll talk about. The rest of it will be secondary disorders, if you will. There are a lot of genetic disorders with how the body manages all these different lipoproteins, for example, but the most common one is familial hypercholesterolemia, specifically type 2A. And this is where there's a dysfunction of the LDL receptor, mainly on the liver, because that's our main organ that takes up LDL from the circulation. And so either dysfunction or of the LDL receptor itself or a decreased quantity of LDL receptors on the liver decreases LDL uptake, so therefore more remains in the circulation, less of it gets catabolized or metabolized, okay, and less of it gets eliminated. So typically what will happen if anybody has this genetic variant and they're heterozygous, in other words, they only have one bad gene and one good gene, their LDL levels will be reasonably high, moderately high, 250 to 500. Okay, that's still pretty high by all accounts, right? And they'll tend to have evidence of cardiovascular, some sort of atherosclerotic disease much earlier in life than typically, probably around 60 or so years of age, where you typically expect to have some evidence of cardiovascular disease without atherosclerosis. But these patients will have it a little bit earlier, say 50, maybe even 40. Okay? If, in a rare case, not very common at all, the patient has both genes bad, homozygous, their cholesterol levels will be very high. They'll be very high as a child, for example, and they'll tend to get these clinical manifestations during childhood because their concentrations of LDL are so high, they begin to rapidly develop signs and symptoms of disease. And we'll talk about those various types of diseases as we move forward. But as we mentioned before, a lot of hyperlipidemia is due to secondary causes, primarily diet, right? So it'll be a high-fat diet, high-carbohydrate diet, stores everything as fat. Those are very high risk factors for lipid disorders. Certain drugs can exacerbate that. I can't think of a drug that would cause significant hyperlipidemia by itself, but they can exacerbate an underlying condition. I'm not going to ask you what those drugs are. I'm just making you aware that it's possible. And then, as we mentioned before, certain diseases, obesity, diabetes, hypothyroidism that we already spoke of. Nephrotic syndrome, also increased lipoprotein concentrations as well. And then obstructive liver disease as a last example. But definitely diabetes and obesity are prime hyperlipidemia disorders. But keep in mind, you can have a secondary disorder on top of a genetic disease that augments that process. What are some of the clinical manifestations that we expect to see? Not very commonly will you see xanthomas unless the concentration of cholesterol is really high. Okay, you can see these cholesterol deposits, these fatty deposits, particularly at joints, flexure joints, where tendons are. So here you can see the knuckles, the elbows, the knees. Hard to see in this picture, but fatty deposits around the eye, little small, almost acne-like formations, but they're really made of lipid. Okay, so you can see those, but the concentrations typically have to be really high in order to be able to see it. So you won't see that in your typical patient that has hyperlipidemia of more moderate elevations of cholesterol, for example. Specifically towards hypertriglyceridemia, having prolonged high triglycerides is a risk factor for pancreatitis, inflammation, damage to the pancreas. We'll talk about that a little bit when we get to the pancreatitis section, but just so you know that is a very specific, unique damage to an organ based on triglycerides only. However, most of what we're concerned about is all of these things here. And this is what you'll see in the vast majority of your patients, okay, is the product of atherosclerosis. And particularly what we're going to talk about is that related to coronary. We'll talk about it as it relates to carotids and cerebral when we get to our neurology section, because it's a result of stroke, ischemic stroke. We'll talk a little bit about aortic thoracic aneurysms today. Talk a little bit about peripheral arterial disease as a result. We won't go into the mesentery or renal arteries, although we've mentioned that especially the renal arteries can be, blood flow can be decreased due to plaque formation, so renal artery stenosis, that's what that is. Okay. So all of these things are possible, but certain coronary and carotid arteries and peripheral artery disease are some of the most common that we'll encounter, so we're going to talk about those a little bit more today. Okay. So where do we typically find locations of atherosclerosis? In general, these are obviously identified for you, but it's always on the arterial side, okay? And it tends to occur more commonly where there's high flow, even bifurcations of where blood flows, in other words, a fork in the road. Anytime there's more interaction with the blood vessel itself, physically interacting with that blood vessel, there's more likely plaque formation to occur there. From a disease standpoint, we can find them in the proximal coronary arteries, and that would cause a myocardial infarction. Again, we can find them in a variety of different vessels, particularly the carotid arteries that feed the brain, and those can then cause signs and symptoms of a stroke. And then peripheral arterial disease, where we have plaque formation that forms in the abdominal arteries, iliac arteries, popliteal arteries, for example, all can affect blood flow to distal parts of the body. Peripheral artery disease, but also the kidneys, also perhaps the mesentery or the stomach, if you will. Keep in mind that in any given patient, if you document plaque formation somewhere, for example, coronary arteries is probably one of the most common, you typically would then begin an investigation to make sure, to a certain degree, that, well, does this patient also have evidence of plaque formation in the carotids? Or do they have evidence of plaque formation in the peripheral arteries, for example? So typically you're not just going to get plaque formation in one organ of the body. It's probably elsewhere, whether it's that it's a significant amount. That's hard to say. That's where the investigations come in, or the clinical examination, to see if there's evidence of decreased blood flow to the periphery, for example. Okay? Or we might listen to carotid, we listen for carotid murmurs, carotid ruiz, which indicates that there's turbulent blood flow going to the arteries. With that blood flow, again, that turbulence comes from plaque being there and forcing the blood to not move in a linear fashion, but in a turbulent fashion where it's hitting the blood vessels and causing that noise, right? Okay, so just real quick on treatment of this before we go into the specific disorders, and all of these treatments apply to all of these disorders. And again, I'm not going to ask you specifics on treatment. It's here for your information. Lifestyle modifications are key, right? Changing the diet, particularly limiting saturated fats, is essential to decrease lipid concentrations. But in many patients, we require drug therapy. Okay, so statins are kind of the mainstay. Atorvastatin, rosuvastatin, probably the two most commonly used, particularly if they have evidence of heart disease. Those are going to be used preferentially over the others. But any of them can be used and be effective. When we get to high dose statins, those rosuvastatin and atorvastatins are the ones that are used. And those help decrease cholesterol formation by the body from the liver. And there's a variety of other medications that act in different ways. Bile acid resins, such as cholestyramine, for example, bind cholesterol in the gut, preventing it from being absorbed. Niacin and fibrates decrease the formation of LDL from VLDL. Particularly useful in treating hypertriglyceridemia as well, particularly the fibrates. Ezetimibe blocks cholesterol absorption, so it never gets absorbed. And then lastly, the PCSK9 inhibitors block the degradation of LDL receptors, okay, maintaining their viability in the liver, for example, such that LDL can be taken up in a regular fashion. So that's what those medications do. So just a little bit of information for you. Now we'll dive in and talk about these disorders specifically, beginning with arterial disorders. So today we're just going to talk about peripheral arterial disease and aneurysms, and then next quarter we'll talk about stroke, and then really in the next slide deck, the second half of today, we'll talk about heart disease, particularly myocardial infarction. Okay, so peripheral arterial disease sometimes can be called arterial sclerosis obliterans. Most commonly, peripheral arterial disease is just a little easier to say. And what I've done here is circled the most common arteries that are affected. Femoral artery and popliteal arteries is where these plaques tend to form more commonly than others, but they can form in others. It's just the most common. And as you would expect with any atherosclerosis disease, that the incidence of this will increase with age. Okay, so again, you guys all are probably very healthy from that standpoint, but if you were to look at your arteries, there are probably, most of you would have fatty streaks in them. Maybe some small minor plaque development given your age, right? And that would just increase depending on the risk factors, as we mentioned. So peripheral arterial disease can be asymptomatic. In most cases, anytime you have a plaque lesion, typically you're asymptomatic until at least 50% of the blood vessel is occluded by that plaque. Okay? So typically you wouldn't even know you had plaques present until you have at least 50%. Then you can become symptomatic, particularly with exertion, okay? Because your body needs more oxygen, more blood. If you can't supply that, that's when you tend to get the signs and symptoms. The most common signs and symptoms associated with peripheral arterial disease, because it occurs in the legs, will be discomfort, fatigue upon exertion. Most commonly, most people will feel this in the calf because it's below where that plaque is present, and the calf muscle uses the most oxygen of that lower extremity. Okay, so when you're walking, you use your calf muscle to walk. However, there are other exercises, such as swimming, for example, where you don't use your calf muscle nearly as much as walking, so you may not precipitate those signs and symptoms. So it is specific or important to get what kind of exercise they typically do and what symptoms it produces. Okay, so with walking, you'll tend to see it more with other types of exercises because of the involvement of the calf muscle and its use of oxygen. If the pain is at rest, that probably suggests a more severe presentation of disease, such that they can't get enough oxygen, enough blood flow, even when their tissues don't demand a lot of oxygen. Okay, so the blood flow is pretty low in that situation. And in those situations, because the blood flow is so low, they're much more at risk for losing the limb due to gangrene, necrosis, death of those cells, right? So that'd be the worst case scenario. Other things that you might see on physical examination, muscle wasting because it's not getting enough blood, thinning of the skin, losing hair in the lower extremities, all because they're not getting enough blood. There's a variety of reasons for that, but that could be one thing that you look at. But then certainly you would follow that up with palpating typically the pedal pulses. So when you're getting your pulses kicking at your feet, that's what they're looking for, right? And making sure you got adequate blood flow to the distal parts of your limbs to make sure that you don't have any sort of evidence of peripheral arterial disease. We can also be more specific at the diagnosis, and this is really more for your information. If you see anything written in a chart or discussion of ankle brachial index, that's measuring the blood pressures in the arms and then comparing it to the blood pressures along the ankles. Okay. Normally they should be very close, but if the ratio is less than 0.9, that would be consistent with vessel occlusion. Okay. In other words, the pressure is lower in the ankles than it is in the brachial artery. Okay, it has a very high sensitivity and specificity for that. So if you ever see that, that's what it's there for. Very briefly, treatments, lifestyle modifications, is anything that we're probably going to talk about in this realm is getting adequate exercise and changing your diet, obviously, to decrease atherosclerosis. But trying to maintain as much intensity of exercise as you can relative to tolerance and physical signs and symptoms of pain and discomfort. We can use some medications, aspirin, antiplatelet agents to prevent clotting of the blood in there as much as possible, and certain other medications that prevent platelet aggregation as well. Again, all for your information, right? Some patients may have surgical intervention, which is actually fairly common, so if you're not familiar with what that is. So for example, this is where we have an endovascular procedure where they're putting a stent in, and so you can see the stent, in this case, being presented into the area of obstruction. They blow it up with a balloon, and then they put the stent in there, and then that stent just keeps it open, right? Alternatively, if you have more significant disease, they may take a vein from another area of your body and then just bypass this disease section right here, which is getting no flow. So they reestablish blood flow by putting a new vein where before that occlusion, and then restoring blood flow distally past that occlusion. So that would be a FEMPOC bypass, for example, bypassing some of those main arteries that are occluded. So again, just for your information. Lastly, on the arterial side is aneurysms and dissections. Certainly, you're going to probably encounter it in some patient, some way, shape, or form. Do you manage this patient? Probably not a lot, other than some basic drug therapy. But it is important to know what's going on, okay, and the seriousness of the disease. So this is typically a result of atherosclerosis, but more so, not so much on the plaque formation side, but more on the ability of atherosclerosis to weaken arterial walls, particularly high pressure, high volume of blood sort of areas, okay? And it does that by decreasing elastin and collagen formation in those areas. So that's by far the most common etiology, but certainly hypertension, some congenital abnormalities, specific trauma, and certain infections can do that as well. But from our standpoint, we're just going to focus on the atherosclerosis part of it. So aneurysms, what they are a abnormal dilation of blood vessels that occur in the arteries, okay? Really much more so in the arteries, minor, if at all, in the veins, because again, we're looking at a high pressure blood flow, and that'll occur in the arteries. So these are just some very basic types for you to refer to. They get divided into true aneurysms and then false aneurysms. I'll differentiate what that means in a second. But from the true aneurysms, basically what that means is that the entire, mostly the entire circumference of the blood vessel is abnormally weakened and dilated. So what's happening here, for example, the tension of the blood vessel walls itself is not adequate to maintain or regulate the pressure that's upon it from inside the walls, right? So it begins to dilate to relieve that pressure. So that's what you typically see in these full circumference sort of aneurysms, but they don't have to involve the full circumference. It could just be half of the wall or part of the wall. Baryaneurysms tend to occur in this small vessels in the CNS. You can see this one here, and those tend to be mostly within the CNS. False aneurysms are technically aneurysms, but they don't involve necessarily dilation of the vessel wall itself. What happens is that blood, through weakening in the part of the aorta, in this example, finds a hole and begins to basically develop another pathway of flow. I'll show you another diagram that'll make that a little bit easier. So these are called dissections, more commonly than a false aneurysm. So if you know it as a dissection on the exam, that's what you should refer to. So we'll get back to that in just a sec. Aortic aneurysms mostly tend to be abdominal in nature, less than 10% are thoracic. Thoracic are higher up, and so as that aneurysm dilates, right, it tends to compress other areas that are located nearby. So the throat, various laryngeal nerves, the esophagus, the superior vena cava, for example, causing a variety of different symptoms of edema, hoarseness to the voice, inability to swallow, difficulty breathing from tracheal compression. Okay, so it just kind of depends on where it's at. All those things are possible. Am I going to ask you specifics on signs and symptoms of this? No. Okay, this is just not your business to diagnose it. Nobody's going to rely on a pharmacist to diagnose an aneurysm, but just so that you're aware of what you might expect to see. Abdominal aneurysms are obviously lower, so typically you might find a pulsating abdominal mass because of the aneurysm, and typically associated with significant abdominal or back pain, depending on where it's located. The importance of this, obviously, is that they are life-threatening, right? And so the smaller they are, the better. You can monitor them, or you have time for surgical intervention, but if they're large, they're at risk of rupturing open. If they rupture open, all that blood leaks out, it doesn't go to the rest of your body, and you have a significant risk of death. So the treatment's always going to be surgical repair, depending on whether it's urgent or whether it can be monitored and taken care of in a timely manner down the road. The aortic dissections, as I mentioned, are false aneurysms, and we'll show you a picture of what this means. But basically, as I mentioned, so instead of blood flow being confined to this gray area, which is the aorta, a hole develops because of weakening of the aortic wall. A hole develops and blood can leak to the outside, on the outside of the aorta, and basically begins to establish a pattern of flow that's outside of the circulation but surrounds the aorta. Okay, so it's still within the vessel itself, but it's not within the part of the vessel that delivers the blood to the rest of the body. Okay, so what can happen here, and it's not important really that we know the different types from our standpoint, but what can happen is then over time this blood accumulates on the outside of the blood vessel contained by the outer periphery of that blood vessel itself, and it begin to choke off blood flow, okay, from going from the aorta to the rest of the body. Typically associated with really intense sudden onset of pain because that happens fairly rapidly, that tearing of the vessel wall, and creates either chest pain or back pain depending on the location. But definitely an emergent situation because you run the risk of not having blood flow to the rest of the body, so that can cause paralysis, passing out, syncope, heart failure, limb ischemia, whatever's not getting adequate blood flow, depending on where this occurs, is that definitely at risk for significant damage. Where we come in, depending on where this happens, we might provide antihypertensive so that we're limiting the pressure on the vessel wall so there's less blood going into that dissection, if you will, until they can get surgical management. But ultimately it has to be repaired relatively urgently. Okay? All right, now we'll go into venous disorders very quickly and we'll take a break. So we're going to talk about venous thromboembolisms for a good portion, and a little bit about chronic venous disease before we take a break. All right. So to differentiate, make sure that we understand what a thrombus is and what an embolus is. Okay? So a thrombus is a blood clot that forms in a blood vessel. This is your blood vessel, right? And you get a thrombus that forms there for whatever reason. Okay, that's thrombus. If for any reason parts of this, little small parts, may break away and travel through the blood vessel, and then as the blood vessel goes on, it goes to smaller and smaller areas, that dislodged piece may go in here and get trapped within the smaller arteries, right? That's an embolus. Okay? So it's part of the thrombus that is dislodged and travels to another area of the body where it then gets trapped and causes occlusion. Okay? Where does this typically happen? In the venous side, for one. And in part, or in large part, that's because the venous side, compared to the arterial side, is a very low flow, very low pressure system. So it promotes more interaction with the blood mediators of coagulation with the vessel walls. Okay? It's more common to occur in the lower extremities, in the legs than it is the arms, for example. It can occur in the arms, but if it does occur in the arms, most commonly it's not a significant risk. So I can tell you that coming out of my most recent hospitalization, I did have some thrombophlebitis that was totally due to a catheter being in there for 3 or 4 days. But it's not at risk for developing a significant clot or that clot moving anywhere that stays, right? It just resolves on its own. So most of the time when it's in a superficial vein, okay, one of the veins that's smaller, you just observe it, make sure it doesn't get any worse. If you need to intervene, great. But lower risk of any sort of clinical sequela, very low risk of developing a pulmonary embolism. We'll talk about that in a little bit, okay? But should you get a thromboembolism in the deep veins, which are particular in your legs, those are more concerning. Okay, so superficial, not so concerning. Deep veins are very concerning because those tend to be larger, because they're in bigger veins, so they tend to be larger, and then have much more of a risk of pulmonary embolism. So when I say pulmonary embolism, that means that the thrombus that is formed in the leg, that picture here, right, travels to the lungs where it causes a pulmonary embolism. Okay? So depending on the size of that embolism, it could be instant death, or it could be almost asymptomatic. We'll talk about pulmonary embolism when we get to the pulmonary section, but that's what we're concerned about, is because there is significant morbidity and mortality associated with that for a lot of patients. Okay? These are your categories of risk factors. And I say this every single year. I will ask you something on the categories. I will likely ask you something on the examples of those categories in an exam question or multiple. It will be there. So please don't ignore her. And even though I say that, still a lot of students tend to get these questions wrong. All right? This is called Virchow's triad of risk for venous thromboembolism. And it gets categorized into stasis, in other words, low blood flow. Anytime you have that low blood flow, particularly on the venous side, right, you have more opportunity for coagulation mediators, inflammation to interact with the blood vessels and form a thrombus. Any sort of vascular trauma, whether it's from the inside of the blood vessel or external, and situation where the patient might be hypercoagulable, which increases their risk of clotting if they have abnormalities in their clotting system. Okay? So we'll go through examples of each of these. So stasis, what does that mean? What are our risk factors? Typically, the longer somebody is immobile, the more that risk. Okay? So a particular concern, at least from my experience, and there's many other examples, but patients in the ICU that are severely ill, they're not getting up and walking around, right? They may be in the bed, not moving any of parts of their body for several days. So they are at high risk of having a thromboembolism because you're not moving your calf muscles, you're not facilitating the movement of blood by your normal process of walking around, right? So you have higher risk because of even low flow state because of that. Even brief immobility can sometimes occur. So if you've ever heard of people getting a thromboembolism on a very long plane ride, that can happen. You're sitting still. That's why even if you're going overseas internationally, 14-hour plane ride, you got to get up and move. Okay? Because you do have a risk of that. Long travel anywhere, whether it's on a plane or a car, get out and move around. Those are risk factors as well. Anything that will impair perfusion, that will just naturally slow down perfusion to the rest of the body. Heart failure is a big one, right? You get decreased cardiac output because the heart doesn't function as well. You're going to have a lower amount of flow to the rest of the body, a lower intensity of flow, so that increases the risk as well. Any sort of shock syndrome, prolonged dehydration, because you have low blood volume, low flow, but you also concentrate the coagulation factors that are there. Obesity is a risk factor as well. And then lastly, venous catheterization. Definitely lower on the risk factor, particularly because they tend to be in more superficial veins, right? Most of the time that you get a catheter in your vein, it's mostly superficial, not always, but a little bit lower on the risk. But definitely immobility is a huge risk factor. Vascular trauma, either external or internal, say, including damage from hypertension and diabetes, all that could qualify, but most of it tends to be the physical trauma, motor vehicle accidents, whatever it might be, surgical intervention, particularly of high-risk areas with knee surgery and hip surgery. Okay, we'll typically always get some form of prophylaxis to prevent a clot from being formed. But really, any surgery is a risk. Just these ones are listed for you. Okay, and again, venous catheterization technically is a traumatic event to the vein as well, so I put it in two places. Hypercoagulability, the number one cause of somebody being hypercoagulable if they don't have an inherent genetic disorder, and one of the mediators of coagulation is having active cancer. For whatever reason, it increases the quantity or the ability of the factors that are there to form a clot. Okay? So having active cancer is always a risk factor for developing a clot. Other things, antiphospholipid syndrome, acute hospitalization for an acute illness, also a risk factor. And then a variety of genetic disorders, so factor V Leiden deficiency will increase your risk of clotting. Your body's natural anticoagulants are protein C and S as well as antithrombin. So if you have deficiencies in those, you're less likely to be able to balance the clotting factors that are present, right? And then a genetic abnormality producing too much prothrombin will increase the clotting as well. Infection and pregnancy are risk factors, and then importantly from a pharmacist standpoint, as many of you may have been counseled, if you received an oral or any contraceptive that is estrogen-based, it increases your risk of clots as well. Okay, so we always got to make sure that we're warning even young patients that are on contraceptives that are estrogen-based that they have a higher risk of developing a clot. Okay, hopefully, if any of you have received that, you've received that sort of counseling. So here's what's kind of happening at the vessel level, and I've kind of categorized A, B, C, D accordingly, and it goes kind of in the opposite direction here, at least on the figure, but the letters correlate to the same letters that are in the figure. So it really begins with some sort of vascular damage in this example, right, where the platelets begin to adhere to the endothelium as well as leukocytes, or white blood cells. Okay, so they're recognizing some sort of abnormality with the vessel wall. They attach to it and begin to more avidly express tissue factor. Okay, if you remember back to our coagulation cascade, tissue factor is one of those important mediators that starts the coagulation cascade, right? So moving from platelets, now involving the entire coagulation cascade by expression of tissue factor. So that brings in or activates the entire coagulation cascade, forming fibrin as an end product and forming this clot, which then kind of captures whatever seems to be floating by. But it's mostly made of fibrin, red blood cells, platelets, and it begins to include the blood vessel. Okay. Ideally, plasmin, which is our body's natural clot dissolver, hopefully will degrade that in time, okay? But if it takes a while to do that. So if the clot formation is significant, it may not be able to degrade that clot before it begins producing signs and symptoms. Most typically what you'll see, now it can occur in both legs at the same time, okay, but it's not common. Typically it will occur in one leg, so unilateral involvement, okay? A lot of patients will have a DVT and not even know it, because it depends on the size, the location, but also depends on how physically active they might be, their body habitus, that sort of thing. And many of those will have, particularly the asymptomatic, will have it in the calf, which is relatively less clinically significant because it's more superficial. But if they have it in the deep veins, typically what you'll see is what you see here in the picture is unilateral involvement. You can see that the left leg is significantly more swollen than the other. It's significantly more red in color because of the inflammation. Typically, most patients will have some degree of pain and tenderness, particularly around, if you're going to palpate the arteries, if you can. You might be able to feel, or the veins, I should say, you might be able to feel those. So a lot of swelling. Some very non-specific stuff. You might see an elevated white blood cell count. Hard to diagnose it just based on that, but you might see an elevated white blood cell count. You might see an elevated D-dimer. I'll talk to you on the next slide of what that means as a reminder from our coagulation. And then lastly, what we're really trying to avoid is the development of a pulmonary embolism. So as I mentioned, that clot travels from the leg all the way up. The first place it's going to go, the first place it's going to get lodged is in the pulmonary system, which is a vast network of arteries and capillaries, right? So it'll get lodged somewhere in there. If the clot is big enough, it can cause significant deterioration of heart function and lung function. Again, some of them might be small and you might never even know it. Okay, it just kind of depends. But that's what we're trying to do, prevent. So from a workup standpoint, we might get coagulation studies, PT, INR, PTT, we mentioned those before. Gives you an idea of the overall coagulation status, platelet count as well. If we want to look for evidence, is there really a clot there? Okay, we'll get a D-dimer. If you remember what a D-dimer is, it is a byproduct, a degradation product of fibrin. Okay, fibrin is part of that clot. So if you have positive D-dimer, I'm not going to ask you the concentrations here, I'll just say whether it's absent, normal, or positive. But if you have positive D-dimer, that means that somewhere in your body there's a clot that's being degraded by plasma. Okay, it's degrading that fibrin and releasing the degradation products into the circulation. Doesn't mean that it is necessarily a DVT, but if the clinical situation says you probably have a DVT and you have a positive D-dimer, then that's probably a good correlate, right? If it's negative, pretty sensitive in that you probably don't have a clot. You should look for some other sort of etiology, okay? So D-dimer can be very effective in kind of deciding where to go and what level of intensity of investigation you need. All right. So how do we prevent these? This is again more on the treatment stuff that I won't necessarily ask you. But we look at all the risk factors, right? So for example, if you're hospitalized and you can get up and move around, if any of you have been hospitalized for a day or two, you know that the nurses are very interested in getting up and moving you around. It's not just to get you a little bit of exercise, it's to get your calf muscles moving so that you push blood sufficiently so that you increase the blood flow coming from your legs, right? So you increase mobility as much as possible, right? If you can't do that, what they'll tend to do is they'll put little compression devices around your legs and they'll squeeze, relax, squeeze, relax, squeeze, relax to physically compress your legs and force that blood out a little bit more. I've had those, they're kind of annoying to sleep with, to be honest with you, but they're effective. Or you might have compression stockings to compress those lower legs to stimulate blood flow back up to the periphery, or back to the heart, I should say. If you're hypercoagulable for any reason, whether it's stasis or you have a hypercoagulability and you can't move, it's very likely in the hospital you might receive a low dose of an anticoagulant to prevent that clot from forming. So a low dose heparin, low dose molecular weight sort of heparin will help prevent that clot from forming, particularly if you can't be mobile. And then preventing any vascular injury is obviously key importance as well. How would we treat this if we need to? In a case of a pulmonary embolism, for example, we might give a medication called TPA. This is something that activates plasmin, so that plasmin can quickly begin to degrade the clot and open up that artery. This would be used in an emergent situation of a large pulmonary embolism, for example, to kind of lyse open that clot. Okay, it does come with an increased risk of bleeding, so we can't use it in everybody. So that'll help dissolve the clot. Thrombolytic will help dissolve, lyse the clot. Anticoagulant therapy doesn't dissolve the clot, but it helps prevent more clot from being formed. Okay, big difference there. In that situation, you're letting the body slowly use its own plasmin to degrade that clot. Okay, so host of different anticoagulants, warfarin, used to be kind of the mainstay, but now it's kind of being replaced by a variety of new agents that suppress specific inhibitors. I'll leave those for you to look at. But a variety of different things we can do to prevent that coagulation cascade and allow the body to get rid of the clot on its own. Okay, lastly we'll go quickly through venous disorders and then we'll take a break. All right, or I should say the second venous disorder is chronic venous disease real quickly. It's a result of increased pressure on the veins. Okay, typically it occurs because of incompetent vein valves. We've talked about that a little bit before. I'll show you a picture of what that looks like specifically. But it's really increased pressure on those lower extremities due to blood flow, due to gravity, that's causing those issues. Okay. Ultimately, what that means is that it is also, because more blood is pooling and increasing pressure in the legs, that means that's less blood flow, less pressure coming back to the heart in the most severe cases. Okay. That stimulates an inflammatory process. Because of that, increased stress on the vessel walls, increased pressure on the vessel walls, maybe accompanied by hypoxia as well. And then the veins will try to remodel to account for that, so they'll become thick and dilated to try and account for that increased pressure, try to combat it, if you will, but ultimately not particularly effective in the long term. Increase with risk of age, might be some gender associations as well. Obesity, sedentary lifestyle, so prolonged sitting and prolonged standing can both potentially exacerbate chronic venous disease, because you're not moving around when you're sitting. So that's one aspect. But prolonged standing means that it's more likely for that blood to pool in your legs, potentially, right? Smoking causes vascular damage, so that's a risk factor. Congenital diseases from genetics, and then there is some association with patients that are particularly tall, just because they have more of a gravitational force. That might be a risk as well. So ultimately, really what happens is this is our normal situation here in our calf muscle and our valves that are operating normally. And so when you're walking, for example, and your calf contracts, it pushes against and narrows the veins, correct? And that pushes blood superior towards the heart, right? And the valve below it remains closed. So it prevents blood from going down and forces it to go up, right? So that's the value of your valve muscles that are in your leg. And then once it gets your abdominal area, then the respirations in and out help pulsate that blood forward as well. But what happens when we have valve disease in this situation, so most commonly, most of the blood returns to your heart via your deep veins. Okay, so these more superficial veins over here all typically mostly drain into the main deep veins. Okay, but they're operated and regulated by valves as well. So when your calf contracts, in this situation here, we have a faulty valve. So instead of pushing the blood all the way forward, some of it goes back over here through that incompetent valve and back into the superficial vein. That's where you see a lot of that venous distortion, dilated veins, varicose veins. That's what those are. Okay? And so the blood is just going into that reservoir and not necessarily moving up. Okay? If you have valve damage that's below here in the deep vein as well, then you're going to get some blood that goes down instead of up. Okay? So it'll typically it's a progressive disease, so it'll start with something like varicose veins, which I'll show you another picture of, telangiectasis, which are these dilated capillaries because of the increased pressure, reticular veins, which are small dilated veins that typically appear blue under the skin. Okay, and then as it progresses, you get that heaviness and pain, intermittent claudication because of that increased pressure from too much blood in the legs. And then long-term, more severe complications can run into edema, pigment changes, ulceration of the skin, which I'll show you on the next couple slides as well. So definitely can be a progressive disease. Ultimately, what's happening at the venous kind of level is permeability of the vein is increasing, and so you get a lot of things that are normally contained within the veins that now are allowed to leak out. Okay, so leukocytes or white blood cells, red blood cells get extravasated as well. They get eaten up by mast cells and macrophages, which then creates this homocysteine. So that's where you get the discoloration, right? You get the red blood cells leaking out of the blood vessels and then getting phagocytized by these macrophages, for example, and that causes that discoloration, which I'll show you in the next slide. Pro-inflammatory state, which causes some vascular remodeling, as we mentioned before, and decreased elastin synthesis. So this is just an example of typically what we'll see in a patient that has varicose veins. You see these very dilated, engorged veins that are on the superficial level. Okay, and again, this clear indication of significant disease here, but also means that there's decreased return of blood to the heart, which can be problematic. And then these are some of the things that we talked about. Dilated veins we saw in the last slide. See some edema here. We can see some fibrotic changes of the skin. So you see these kind of leathery sort of formation of skin. That's dermatosclerosis. Here we can see the red. Here and here we can see the pigmentation caused by red blood cells leaking out of the vessels. And then lastly, a little bit harder to see, but you can see a little bit of ulceration in this lower thing caused by venous stasis. And so very common etiology for venous ulcers to develop. Okay. Symptomatically, again, the patient will typically feel heaviness of their legs, very tired upon exertion, intermittent claudication, which is pain during walking, pain during ambulation. That's what that refers to. Okay. So you'll see this occasionally in patients, so it's kind of important to recognize what some of those look like. And I'll end there for now, and then we'll continue after a 10-minute break, and we'll talk more about pure cardiac disease more moving forward, which is much more exciting than this stuff, to be honest with you. So, all right, I'll take a break. If you have any questions, just let me know. Come on out.
I didn't see him yet. Pretty good. I didn't get to really study.
Remember that idiot said I was good? He saw his review response.
I mean, like, we were friends as well from SIU. So, like Friday, I was out.
Like, I didn't grade it.
I'm going up on Saturday night. And then I came back Sunday. I really got to sleep. It's okay. It's okay. I'm gonna check it out though. I don't know. Because I don't know if they put it.
Hope we got fun.
Yeah.
Hope we got the fun. Like, we got some 5 out of 5. We got that shit.
It's okay. We're gonna see though. We're gonna see. You guys take it on paper?
Mine is like half filled.
I don't get it. I didn't get it yet because I took it on paper.
Don't look at it.
I've been seeing the scores. Don't get me wrong. It's really good stuff.
Sorry, I keep nodding off. I know you see you looking, making eye contact. Okay, good. Oh, I'm sorry, Dr. Haynes.
It's not my favorite life, I'll tell you that. So I'll take some more to show.
You know, we had the pharmaceuticals in, so I was up, you know. I know I'm not supposed to, but Yeah,
Sleep is good.
Yeah.
Hopefully it went well for you.
I did have a question actually. When you were talking about the D dimer for the like to see if they had a clot before, if it already traveled to the lungs, would you still do a D dimer or would you just do a ultrasound?
If there's a clot in the body and the body's degrading it like it normally should, you will see D-dimer.
Regardless of where it's at.
Yeah, it doesn't matter where it's at.
Oh, okay.
That's what I said. It's not specific. In other words, it doesn't say, oh, you have a DVT. It just says there's a clot somewhere in your body.
Okay.
So if the clinical situation fits a DVT, then you would make that assumption.
Gotcha. I was wondering if it was in the lungs, was it still going to have like the same, Gotcha. Okay, cool. Thank you.
Yeah, so like people with small clots in their lungs, they may never know. Eventually their body will dissolve those clots over time, but they may never know.
Gotcha. Thank you.
She was looking at you, she was like, I'll do it. I'll come back. What do you guys do? Don't worry about it, bro. Yeah, that's how much we Zero?
Okay, let's get started. And before I forget, if everybody could open up your Cadley app and we'll officially do attendance. We'll begin that process. Okay, should stay open for a couple minutes. In the meantime, so now, like I said, we're going to move into pretty much everything here right now. We'll just be specifically talking about the heart, which I find much more interesting, say, compared to the last lecture. So thank you for trying to pay attention to that. But I think the rest of the stuff is much more interesting. At least hope you do. So we'll talk about disorders of cardiac function, beginning with really atherosclerosis as it pertains to the heart. So I'll let you look at those learning objectives on your own. So coronary artery disease can present in many different ways. Okay, so we'll touch base on each of these for the most part. Stable ischemic heart disease, okay, sometimes called or referred to as angina. Angina just means chest pain. Angina pectoris technically means chest pain. Okay, so we'll talk about these individually. We can also get angina through what we call variant angina or Prince-Metal's disease. This one has nothing to do with atherosclerosis per se, but it is an inadvertent vasospasm of the coronary arteries such that it severely decreases blood flow. It really doesn't have much intervention in the way of getting rid of the plaque or treating the plaque. It's really just a spastic disease of the coronary arteries. So we won't talk about that any further, but that's what that refers to. So we'll talk about ischemic heart disease and then acute coronary syndromes, which consist of unstable angina, non-ST elevated MIs, and then ST elevated MIs. Okay. I'll define what those are a little bit further along. They'll become a little bit clearer as I refer to those. Okay. So all of this overall is simply a product of how much oxygen does the myocardium need and how much oxygen is it getting. Okay. It's a supply and demand issue, pure and simple. So identifying those things that are causing increased demand, and or identifying those things that are causing decreased oxygen supply. Okay, if everything's in balance, we're all good. Okay, there's no chest pain, there's no acute coronary syndromes, anything like that. Okay, where it relates to atherosclerosis is typically that is the kind of center of focus in causing issues, right? So, out of curiosity, what is your knowledge of how myocardial infarctions form from a atherosclerotic plaque? What happens? You don't have to do it. I'm just kind of seeing where you guys are at. What happens? Is it a slow growth of that plaque that eventually completely occludes the blood vessel? Or is it something different? Any thoughts? Nobody wants to take a guess. No points at that. Okay. It's much less common for it to be a slow progressional growth of that plaque that totally includes the vessel. Okay? That used to be kind of a thought process, I think, as far as what we thought was happening. So it's definitely a factor. Okay? We know that. But when it comes to an acute myocardial infarction, the plaque needs to be there for one, but it's usually a rupture of that plaque that causes the infarction. Okay? We'll talk about that in a little bit more detail. But it does fix the oxygen supply. In other words, it does narrow how much blood can get past it, depending on how significant that plaque is. Okay? And it's fixed. It won't change. Okay? So here are the determinants of supply and demand, if you will. Okay? And keep in mind that there's not a lot of reserve in the myocardial tissue. It uses almost all of the oxygen that is presented to it. Okay? So it takes away generally about 75-80% of the oxygen out of the blood and uses it. Okay? So there's not a huge reserve to go off. So let's talk about those things that are important for oxygen supply. One, just kind of makes sense. We have to have oxygen, right? If we don't have enough oxygen, there's nothing we can do beyond that. So what are some probably relatively unique, rare situations where oxygen may not be as available as it normally is? Anybody think of anything? Anemia? That would probably be more on the hemoglobin side of things. We have enough oxygen. We just don't have enough blood cells to carry it. Okay? So that's where the hemoglobin comes in. You can have plenty of oxygen, but if you're anemic and you don't have enough red blood cells, remember that 99% of the oxygen in your blood gets to where it's going via red blood cells. Very little of it is dissolved in the blood itself. Okay? All right. What about oxygen itself? What are situations where there might not be as much oxygen as you normally do? High altitude. Right. That's probably the most common. So when we travel to Denver or something like that, or any sort of high altitude place, there's less oxygen there. Okay? Your body's not used to it. You get more short of breath because of that. You don't have those adaptive mechanisms. Anything that would cause some sort of asphyxia, usually they're more transient in nature, that would be the most common. All right, so hemoglobin. We have oxygen, right? We need something to carry the oxygen from the heart. Once it gets, the red blood cells get oxygenated by the lungs, goes to the heart, pumps it out to the rest of the body so that it can be used. So it needs adequate amounts of red blood cells. Okay? Whatever the cause might be, if you have decreased hemoglobin, either due to blood loss or to iron deficiency anemia or whatever it might be, that can be a carrying issue of oxygen to the tissues. Then we need something, we have enough carrier, say where hemoglobin's just fine, we need adequate cardiac output. We need something to push that blood, push that carrier of oxygen to the rest of the body. So if you have a low cardiac output, you're delivering less oxygen for a given time, right? Because you have less blood flow. So that could be an issue as well. Heart rate is on both sides of this, okay? From a supply standpoint, we'll talk about that on the next slide. Okay? We always think of it more on the demand side, but it does have an issue with supply. We'll talk about that on the next slide. It'll become a little easier. And then lastly, a patent artery. In other words, an artery that's open. An artery that will allow blood flow to go through it. That's where the atherosclerosis comes in, where depending on the size of that plaque, okay, it may significantly occlude it. And again, back to the same thing we talked about before. Typically, most patients are asymptomatic, even on exertion, if they have 50% or less of their blood vessels occluded by that plaque. Okay? As it slowly gets to be more than 50%, you'll begin to see more signs and symptoms when that patient is exerting themselves, exercise, or whatever it might be. They'll start to become symptomatic. In this case, maybe have some chest pain that will accompany that. Okay? All right, now let's talk about coronary blood flow itself. Okay? This, just to orient you, is a picture of the very proximal part of the aorta and these cusps here that they refer to as semilunar valve cusp. This is the aortic valve. Okay? So just below this is the left ventricle. Okay? So blood is coming from below through this valve and out into the aorta. Okay? Coronary blood flow occurs only when the heart is in diastole. Because when the heart is in diastole, these cusps close, preventing backflow into the left ventricle, right? So they close, but in doing so, they create a bit of a cavity, right? And blood, some of the blood that doesn't all go out to the periphery, to the tissue, some of it retrograde comes back here and pools in these cusps. And you can see that there's two openings. This is how blood goes from the aorta into the coronary blood vessels during diastole. It goes through these little openings that it can only go through when the blood is pooling here during diastole. Okay? So that's how blood flow goes into the coronary arteries. It's the blood flow through those coronary arteries can be mediated by some of the same things we talked about before. So largely, vasoconstriction is going to occur through the sympathetic nervous system. So through the alpha-1 receptor of epinephrine as a mediator, or maybe even norepinephrine as a mediator. Endothelin-1 is a potent vasoconstrictor of the coronary arteries as well. And then vasodilation occurs through 1-nitric oxide, which we've talked about before. Okay? But also in this case, relative specific to coronary arteries is adenosine. Okay? When you exercise or you have some sort of increased demand on the heart cells produce a lot of adenosine, and that helps vasodilate the coronary arteries. Okay? 4 to 5 times their typical radius, it'll increase. Okay? Or at least the blood flow will increase 4 to 5 times, I should say. Any patient that's hypoxic for any reason, it's going to try and augment delivery by vasodilating. To try and get more oxygen there, if that's possible, right? So those are the things that control vasoconstriction, vasodilation. Coronary arteries are going to automatically constrict or dilate as they need to get less or more blood according to how much oxygen they need. Okay, that auto-regulation sort of thing. All right, now back to heart rate as to why perhaps it might, as we mentioned on this slide, have an impact on supply of blood. Okay, so as your heart rate increases, okay, you spend quantitatively less time in diastole, right? Because your cycles increase significantly, you spend less time in diastole. What that means is that in the heart itself, the left ventricle itself, if you spend less time in diastole, that's when the left ventricle is getting filled with blood, right? So now you have less blood being pumped out during systole because there's not enough time for it to completely fill during diastole. So there's a less volume of blood being pumped out per stroke volume. Okay. In addition, there's less time, now that you increase your heart rate, there's less time for it to perfuse through these coronary arteries because it starts perfusing, but then goes right back into systole again. What happens during systole? The heart compresses to force the blood out, right? Well, it compresses all those arteries too. So you get less blood flow through the coronary arteries, even if there's blood there in the coronary arteries, because it's being compressed, right? So heart rate in those senses has a deleterious effect, a decreased effect on coronary blood supply, okay? In addition to demand, because as you might expect, the more demand there is, the harder it has to work, the more oxygen it needs, okay? So let me go back, because I didn't talk about these individually. So heart rate, the more it has to beat, the more oxygen it needs to do that, okay? You're going to need more increased oxygen demand. Contractility, and the harder your heart has to contract, and that can be stimulated by beta-1 receptors as well. Okay, certain drugs will stimulate beta-1 receptors. Okay, epinephrine, for example, will stimulate beta-1 receptors and increase the force of contraction. Anytime your heart has to do more work, it needs more oxygen. So contractility, heart rate will increase demand. Preload, afterload. Again, preload is the amount of blood that is present in the left ventricle just prior to systole. The larger the amount of fluid there, or blood there, the more the heart has to work to get it out, so you increase demand there as well. Afterload is the resistance that the heart has to pump against. The more resistance there is, in other words, the higher your blood pressure, that's a synonymous effect, the harder the heart has to work to get it out. Okay, so it typically will form more heart muscle, hypertrophy, to overcome that. So again, all those things create more oxygen demand. That supply has to increase to meet that increased demand. If it doesn't, that's where we start to get signs and symptoms of ischemic heart disease. Okay? All right. So this is where hopefully we all should be, as a very open, no plaque in your arteries whatsoever. But in reality, we're probably somewhere, most of you guys anyway, are probably somewhere in between here and here, maybe a very small fatty streak or very small amount of plaque development, and that's just part of aging, right? So this is not going to cause any sort of coronary syndrome whatsoever in this state. Where we start to get into the ischemic heart disease realm, beginning with stable angina, is when we get some significant, say like at least 50% occlusion of a coronary vessel. Okay, so there's enough blood flow there to meet the tissue demands of oxygen at rest. The heart is not saying, I need a lot of oxygen, heart rate's not elevated, contractility's not elevated for any reason, right? So the amount of blood coming in, adequate. We don't get signs of symptoms, okay? So that's stable angina. Even if we start to exercise and we begin to get chest pain because we have ischemia, not enough blood flow, but as soon as we rest, it goes away. Now we've restored the adequate amount of oxygen delivery to meet the demand, right? So typically stable angina, no symptoms at rest, but on exertion, you might get those symptoms. You go back to resting, those symptoms tend to go away because now you're able to meet the demand of oxygen supply. Supply is able to meet the demand, I should say. We'll talk about these other syndromes as we move along here a little bit. So we'll begin with a little bit more on the blood supply, okay? It can occur anywhere within the coronary vessels, okay, coronary arteries, I should say, but most commonly it occurs most commonly probably in the left anterior descending, or the LAD, the circumflex branch off of the left coronary artery, which is this one here, and then the right coronary artery, okay? So as you might imagine, the more proximal you have that occlusion or stenosis, whatever might be occurring at the time, the more heart muscle is going to be damaged, right? So I'm sure at some point you guys have heard the term widowmaker as far as a myocardial infarction. Okay, that's this one here. Okay, because the reason it is because it supplies so much blood, particularly to the left part of the heart, that if you occlude it way up here, there's virtually no blood flow to most of the heart. Okay, so prolonged would kill off that tissue, be non-functional, you wouldn't have any cardiac output. Okay, so that's why the widowmaker stuff. Just for point of reference, I was really hoping I could have access to my own medical files and have pictures and stuff, but I don't have the access of EKGs and all of the angiography. But by all accounts, my first heart attack was right here. So I was fortunate in that it was in the distal part of the LAD after this diagonal, but it still affected quite a bit of significant amount, at least any of the left ventricle and the septum. So lucky in a sense that it wasn't up here, that it was down here. And so they put in a stent. I'll show you what that looks like in a little bit, and opened it back up. So just for reference, okay? What are the presentation? What is it based on? A lot of it depends on the plaque, right? Where it's at, like I just mentioned, will give you an indication of the amount of damage that could be there. But some of it depends on the plaque itself. There's something called what we call non-vulnerable and vulnerable plaques. Some plaques, for whatever reasons, I don't think they know all the reasons why, are prone to rupture. They have very thin caps, high amount of lipid on the inside of them. I'm sure Dr. Shaheed mentioned that. I think those foam cells on the inside. And they're prone to rupture, particularly under hemodynamic stress. Okay? And those are the ones that will cause the myocardial infarctions. A stable plaque might just be fixed. It may never rupture at all, okay? Less likely to cause an MI, for sure, but certainly can be involved with ischemia. So that's kind of the difference between all of those, right? The more prolonged the obstruction is, let's say that, for example, let's say that you have a plaque obstruction of, 80% for years, right? Your body recognizes that it's not getting enough blood supply. It'll eventually create a little bit of, just for drawing purposes, what we call collateral blood supply. So in other words, you have a coronary artery here that's significantly obstructed, let's say 70, 80%, say 80%. And your blood supply is limited to this, right? Because in these areas here that are affected by atherosclerosis, they don't vasodilate. Even though your body wants to, they don't vasodilate. Okay, so it's a very fixed obstruction. But the body does recognize, particularly if that obstruction is there for a long period of time, and it'll form new blood vessels, what we call collateral blood vessels, that can bypass that obstruction. So many patients that may have significant obstruction over time may be relatively asymptomatic because they have alternate blood supply avenues. Typically that's enough to provide them blood supply at rest, but if on heavy exertion, typically they'll still get signs and symptoms. Okay? But that's not going to occur if you have an acute obstruction from a thrombus that occurs over minutes to hours. That collateral blood vessel is not going to form in that period of time. Okay? Keep in mind that patients that have very sedentary lifestyles, they don't do a lot of exertion, they may have significant coronary artery disease and never know it because they're not exerting themselves to produce those symptoms. Patients with diabetes or any sort of neuropathy may never feel that they're having a heart attack, for example, so some things just to keep in mind. Okay? All right. What's the typical presentation? This applies to stable angina, but also all the acute coronary syndromes. Typically, we say chest pain. Well, I would say that it can be a combination of pain and pressure. I would say, in my own experience, sadly, that the first episode, there was a combination of pain, but definitely some pressure. The second one was definitely some pressure. Sometimes you'll hear the term, it feels like an elephant sitting on your chest. I wouldn't say it's quite that dramatic. Anybody have cats here? You know how they have the ability to put all their weight on one paw and it feels like they weigh 50 pounds? That's what it feels like. Not an elephant, that's that cat on your chest. But it does feel like, in my case, it definitely does feel like the squeezing is coming from inside. You definitely feel that suffocating sort of squeezing feeling. And there was pain there as well. For me, it was in the chest, and then later it did radiate to my shoulder. Yes? Mm-hmm. Yeah, the pain can be different, completely different between people. One, it depends on where it's at in the heart, what sort of kind of ancillary nerves it's hitting or affected. So that's why you get some of the radiation on the arms, to the jaw, for example, is that it's inflaming other nerves that are kind of connected around the heart, if you will. So it kind of depends on there. If you have any sort of neuropathy, for example, if you have diabetes, you might not feel that pain sensation at all. Women tend to be far more asymptomatic than men overall. Okay, so and that's why some people have heart attacks and never know it. Some are very obvious. Some may never know it. Okay, so this red pattern here is really the common distribution pattern that some patients may have. They may not have it all. They may just have one of these things. For me, it was definitely the substernal chest pressure and radiating to the shoulder. I didn't get so much to the jaw. I didn't get so much to the arms, anything like that. But as you can imagine, particularly if it's here and it's more pain than pressure, a lot of patients will confuse that with heartburn and not go and get medical attention and ultimately have a heart attack with very little time for intervention. Okay, so it's very common. What does the presentation look like if we begin to differentiate it between stable and unstable? So in stable, again, at rest, no issues, right? They only get the chest pain or pressure, whatever it might be, when they begin to exert themselves in whatever physical activity, whatever it might be. But also keep in mind it could be precipitated by not only things that will increase their oxygen demand, but perhaps alter their supply as well. So cold temperatures promote vasoconstriction, right? Emotional stress, a lot of epinephrine release there. You get some vasoconstriction, but you're also going to get some alpha and beta 1 activity, increasing both supply and demand. So any sort of emotional stress, but definitely physical exertion will typically trigger it. But usually, once the patient realizes, oh, that doesn't feel good, maybe I'm exerting myself too much, they sit down and rest and it goes away. That's usually consistent with that fixed plaque. It doesn't have a thrombus on there, but it's a fixed plaque, and you're just not getting enough blood supply when you begin to exert yourself. Okay? So resting, relaxation, nitroglycerin. If anybody's dispensed or knows somebody that has a nitroglycerin in a little glass vial, put that under your tongue. It really basically what it does is stimulates the formation of nitric oxide, potent vasodilator. Okay, I got that on my second heart attack in the ambulance. It was magic. It just took the pain and pressure away immediately, which was great. Still had other issues to deal with, but it worked really well. So if you're not relieved by rest or nitroglycerin, for example, one, it might not be myocardial in origin. Okay? It could be reflux or some other sort of indication causing some chest pain. Or it could be that you're just rapidly progressing and having more of an acute coronary syndrome, unstable angina, or one of the MIs that you need to seek help immediately, right? Unstable would be defined as that pain doesn't go away when you rest, okay? In other words, the supply is not meeting the demand even when you're at rest. So you're not getting adequate amount of blood flow, so the obstruction is more significant but not complete, okay? Typically the pain is a little bit more severe. If you've had stable angina in the past, this will feel a little bit different, okay? It'll feel a little bit more significant. So now if we move into these acute coronary syndromes, which includes unstable angina, so what's happening in the vessel. So with unstable angina, we're beginning to get some platelet aggregation, maybe a little bit of thrombus formation, but you're still getting blood flow, okay? Not severely decreased blood flow that is causing infarction of the tissue, just causing ischemia. So the cells are struggling to keep up and remain viable, but they can still do so. So you don't have dead heart cells as a result of unstable angina. As we progress to non-ST elevated MIs, and we'll tell you what that means, there's a more significant obstruction of the blood vessel, usually due to, in this case, thrombus beginning to form. Okay? There's still some blood flow there, but the reduction in blood flow is significant enough that you start to begin to infarct the tissue. In other words, you're creating dead myocardial tissue at this point. Okay? ST elevated MIs, complete obstruction of the vessel. Okay? No blood flow whatsoever. We'll talk about what some of these things mean in a different context in a bit, right? So again, back to non-ST elevated MIs. There's still some blood flow there, but not enough. Typically what this results in is that you're infarcting a smaller part here in blue, a smaller part. This is a cross-section of the heart. So we're looking basically down on the heart and doing a cross-section horizontally, right? So this is your left ventricle. So it's just the superior, or I should say, internal portion of the heart wall that has been infarcted and has been affected. Okay, so much smaller. Sometimes called that subendocardial partial thickness infarction. ST elevated MI, again, full occlusion of the coronary artery, whatever that might be, is also called a transmural. In other words, transmural being full thickness of the heart wall. So everything in blue here, full thickness of the heart wall, this entire wall is infarcted, it's dead tissue. Okay? So, unfortunately, my first myocardial infarction was this one. My second was this one. I must have some collateral blood supply because it said it was 99% occluded, so I wasn't having much blood that was going through it. But that's the difference, okay? So as you can imagine, an STMI or a transmural MI is much more significant because all this tissue isn't coming back. It's not going to be revived in any way. So it's not going to participate in ejecting blood from the left ventricle, right? Okay? So that's where you get your decreased ejection fraction when you have an MI, for example. This would be on necropsy. So this is transmural, you can see. But you can also begin to see how it might affect the rest of your heart. Anybody know what these little stringy things are? Anybody remember or what they do? They're the chordae tendineae, but they're the ones that attach to the wall, from the wall to the valves of the heart. So they're very important in coordinating the opening and closing of your valves. So in the left ventricle, these would be most consistent with having mitral disease. Okay? So I have a little bit of mitral regurgitation as a result of that on my own, but not significant, so I'm fortunate about that. This is really the same graph, talking about clinical presentation. As you can imagine, typically the presentation from angina to a ST elevated MI, the severity is significantly increased, right? The pain, the pressure is much more significant. Many patients may feel a sense of doom, if you will. I can't say I felt that, but I definitely knew something was not right. And so you get that intervention. It's not something you go, oh, this is probably heartburn. No, there's no way of confusing that, right? Some patients might get some GI symptoms, which can confuse their interpretation of it as well. When this happens, sympathetic discharge is huge. Blood pressure will go up, heart rate will go up, you will start sweating typically for no reason. You're at rest, but you're sweating, right? So that happened to me as well. If it's a significant portion of the cardiac vasculature that's impacted or muscle that's being included, this is where you can get sudden cardiac death, right? This is the widowmaker, sort of thing, where it just happens in the wrong spot, and there's no viability to return blood flow early enough to save that patient's life. So this is now where we talk about, okay, we're talking about ST and non-ST, STMI. What does that mean? Okay, it relates to the EKG. Okay, and so typical patterns that you'd expect to see if you're having a myocardial infarction or ischemia. So this is normal. So we have our P wave, okay, or our P wave here, I should say, Q, R, S, and then our T wave. That's a normal EKG. Okay, we'll talk about details of this later if you're not familiar. Item B would be consistent with ischemia and or a non-ST elevated MI. Okay? The ST comes from QRST. So it's looking at this segment of the EKG. Here, it's at baseline, right? Here, it's suppressed, way below baseline. That means that there's ischemia and or a non-ST elevated MI, which would be infarction. If you have complete occlusion of the vessel, that would typically create an ST elevated MI such that the ST segment should be way down here, but it's way up here. Okay? So I was able to see the EKG from my office. Mine was way, way up there, right? So that's consistent with transmural MI. ST elevated MI, transmural MI are synonymous, if you will. Okay, so that's how we define ST and non-ST elevated MIs, according to that ST segment of the EKG. I've given this in the past on an exam question. I'm not expecting you to read the entire EKG, but you should be able to identify where the ST segment is and tell me whether it's above or below baseline. So in other words, is it ST elevated or is it more related to ischemia? Okay? The other thing that we look at in diagnosing MIs, typically we need the EKG right away, right? That's done, one of the first things to do when you get into the emergency room, for example. But from a confirmatory standpoint, so let's say, for example, the EKG is ST or non-ST elevated MI or just looks like ischemia. The ST segment is depressed. Okay? We can tell a little bit more about what's going on with the heart based on troponins. Troponins are enzymes contained within cardiac muscle, and when that muscle is infarcted or is dead, those cells lyse open, and all the enzymes go into the blood. You can measure that. So normal troponins should be low. Okay, I made a correction here. There should be 0.04 nanograms per ml, or 40 nanograms per liter. So I apologize for that. So typically when somebody's suspected, they'll get serial troponins because they increase over time from the inciting event, right? So it's typically about every 3 hours. So typically if they had a myocardial infarction, you'll see that increase slowly over time, okay? So anything above this would be consistent with a myocardial infarction, okay? So if you, for example, have an EKG that says ST segment is depressed, so it's either just ischemia or there's an infarction that's non-ST elevated, troponins will help you determine which is going on, okay? So if your troponins are normal, that means you're just having some ischemia, and you haven't had any actual infarction and dead tissue inflammation. But if you have troponins that are elevated, that means that you now have infarcted tissue, dead tissue, So you'll see troponins elevated in either an ST elevated MI or a non-ST elevated MI, okay, but not unstable angina. Okay, if unstable angina, you're still getting adequate blood flow, it's just not enough, so you get ischemia, you might get that depression. Does that make sense? And for reference, not that this is a competition or anything above 40 per liter or 0.4 nanograms per ml. On a nanograms per liter standpoint, my highest went to about 30,000. So no doubt I was having myocardial infarction, right? Wasn't messing around there on the first one. The second one was much less. So after all of this occurs, okay, unfortunately, if you've had infarcted tissue, okay, either through a non-ST elevated MI, subendocardial, or an ST elevated MI, transmural, you have dead tissue. Okay, it's going to be more significant with ischemia, right? Because it's more tissue affected. The full thickness of that ventricle wall might be affected. That doesn't come back. Okay, the heart will begin to remodel itself a little bit to try and compensate. So other areas of the heart will begin to hypertrophy a little bit to maintain adequate cardiac output, adequate stroke volume in the absence of the other parts of the heart being able to contribute, which can be effective, but it can also cause long-term issues in remodeling as well. So the part of the tissue that's infarcted might thin, might dilate, could either be non-functional, it could create some other issues that we don't need to go down necessarily. We won't be involved with that sort of stuff. But this is definitely where you start to get some of that remodeling process, and some of it, at least short term, can be very effective, and depending on the amount of remodeling that occurs, could be significant down the road. So how do we treat? And again, this next series of slides is more for your information. Obviously, underlying factors that led to it, making sure you're treating hypertension, you're treating your lipid disorders, for example, lifestyle modifications, all of that very effective in decreasing secondary complications or a second complication. Obviously, we're going to give them oxygen as soon as they get to the ER, or whether they need it or not, they're going to get it. We'll look at their blood cell to make sure they have enough red blood cells, make sure they're not anemic, some of those early sort of things. They might get nitroglycerin to vasodilate the coronary arteries to increase supply while we're waiting for more permanent intervention. And we might get surgical intervention. So first time I had a stent placed, very effective. Unfortunately, I'll show you on the next slides, that stent clotted off, which is uncommon, but it still happens. Or we could have bypass grafting, angioplasty, or like I said before, when we're talking about pulmonary embolisms, we could give TPA if it's within a certain period of time after the heart attack to dissolve the clot, okay, without surgical intervention. So that can be done as well. And then secondarily, we want to prevent that clot from forming again. And so we have a variety of antiplatelet agents, because on the arterial side, it's mostly platelet delivered. So all of the medications would be more on the antiplatelet side versus an anticoagulant side, if that makes sense. This is what a stent looks like going through the coronary artery. This is your obstruction here. They go in here with a wire, feed the stent through, and expand it, and it compresses the plaque walls against the artery, and then opens that up. And these stents tend to be infused with certain types of medications that prevent the body from reoccluding, like producing more tissue and reoccluding that, okay? In my case, so this was exactly what happened on my first heart attack, and then probably what they think happened is that where they placed the stent, there was a little bit of plaque here that was left exposed, and that became the focus of formation of a new clot, and that occluded rapidly the second time, okay, because it was just occluded on this front end apparently. So, worst case scenario, you get a bypass graft. These are just two different ways of doing it. They may take a vein out of your leg or a artery out of other parts of the body, and basically they just bypass the area of occlusion. In this case, they're getting blood supply from the subclavian artery to make sure that the rest of this heart is supplied with blood. In this case, they're getting blood supply from the aorta and making sure that this distal part is being supplied with blood. Obviously, the occlusion was up here. So that's, for me, unfortunately, that's probably the next step if it should happen again, because there's no room for another stent to go in there, and they already did angioplasty. If you're not sure what angioplasty is, that's the part where they put a balloon in there and just physically open it up. And they have drug-eluting balloons now, so they can infuse that same drug in there to prevent it from happening again. So those are all interventions. From the supply standpoint, more long-term management, we try to make sure we do everything to increase the supply, right? So we open up the artery, we make sure there's enough oxygen, make sure there's enough hemoglobin, all that good stuff, control the heart rate. But we also want to decrease the demand of the heart, right? So we don't want to leave somebody tapping away at 120. There's no reason to leave them there. We can be just fine living with a heart rate of 70 to 80 or even lower, depends on, right? So that just increases oxygen demand of the heart. So we'll give medications to slow down the heart rate, so we decrease oxygen demand. And in the case of these two agents, they also decrease cardiac contractility, right? So beta blocker blocks beta-1 receptors, so it blocks heart rate, it blocks contractility, it suppresses it, right? Same with these two calcium channel blockers as well. So those can be used to help balance the demand and supply aim of things. Okay? So that's acute coronary syndromes, just from a pathophys standpoint. If you have any questions, let me know. Hang out for a bit or shoot me an email. Our case will probably be related to this on Thursday. We'll be a recitation with teaching students again. And our quiz will be on today's material and last week's material. Okay? All right. Thanks.